Thank you for joining us. I'm Elizabeth Clark. I'm the Director of Education here at Select Data, and today we are going to discuss ICD-10, Education for Clinicians. We are going to review Chapter 18 on symptoms, signs, and ill-defined conditions, and Chapter 19, Injury, Poisonings, and External Causes. Any information made available from this webinar should not be considered legal advice. It is for educational purposes only and does not provide all available information on the subject. Information shared is not a promise or warranty guarantee expressed or implied, and the opinions expressed, discussions undertaken, and materials provided do not represent any official position of Select Data. The objectives of today's webinar: at the conclusion of this webinar, attendees will be able to name two general differences between ICD-9 and ICD-10 documentation requirements for symptoms, signs, and ill-defined conditions, and you will be able to name two general differences between ICD-9 and ICD-10 documentation requirements for injuries, poisonings, and external causes. We'll be able to list documentation differences in ICD-10 for abnormal gait, masses, and edema, and we will list documentation differences in ICD-10 for fractures, open wounds, burns, and poisonings. For general documentation requirements for Chapter 18, the most significant changes related to documentation for symptoms, signs, and ill-defined conditions include site specificity and laterality for some signs and symptoms, such as localized swelling, masses, and lumps of the upper and lower extremities, and more detailed descriptions of signs and symptoms such as malaise and fatigue, which includes specific codes for neoplastic-related fatigue and weakness. Specific identification of test results such as abnormalities of plasma proteins, which includes specific codes for abnormality of albumin, globulin, and alpha-fetoprotein. The most significant changes related to documentation for injury, poisoning, and external causes includes separate codes are now required for each injury unless a combination code is provided. Traumatic injury codes are not used to report normal healing surgical wounds or complications of surgical wounds. This has not changed from ICD-9. An open wound is not used for a surgical wound. An open wound is used to represent a traumatic injury. Codes for adverse effects, poisoning, underdosing, and toxic effects are combination codes that include both the substance taken and the intent. No additional external cause code is reported with these codes. The vast majority of injuries to paired organs and the extremities require documentation of the organ or extremity as to the right or left. We now require laterality for these codes as well. The fracture classification systems used include Neer, Castillo, and Salter-Harris. And fractures now require 7th character extensions, but these extensions will differ from those used for other types of injuries. Now let's get started. Chapter 18, Symptoms, Signs, and Ill-Defined Conditions. For specific documentation requirements, we will focus on some of the more frequently reported symptoms, signs, and ill-defined conditions in home care that have different documentation requirements for ICD-10. This will include abnormal gait, masses or lumps, and edema. For use of symptom codes, codes that describe symptoms and signs are acceptable for reporting purposes when a related, definitive diagnosis has not been established or confirmed by the provider. For symptom codes with a definitive diagnosis, assignment of a sign or symptom code with a definitive diagnosis code is dependent upon whether the symptom is routinely associated with a definitive diagnosis or disease process. When the sign or symptom is not routinely associated with a definitive diagnosis, codes may be reported in addition to related definitive diagnoses, such as the various signs and symptoms associated with complex syndromes. The definitive diagnosis should be sequenced before the symptom code. When the sign or symptom is routinely associated with the disease process, we do not assign the sign or symptom code unless instructions for the category, subcategory, or code itself state that the sign or symptom should be reported additionally. For abnormality of gait, in ICD-10, codes for signs and symptoms related to walking and gait describe conditions more specifically, such as ataxic gait, paralytic gait, or unsteadiness on the feet. There are also codes for difficulty in walking, other specified abnormalities of gait and mobility, and unspecified gait and mobility abnormalities. Now let's compare I-9 versus I-10 terminology. In ICD-9, we had two terms. We had difficulty in walking, which is used for joint disorders such as arthritis or gout. And it hasn't changed with ICD-10. It's still difficulty in walking, not elsewhere classified. Now, if your patient has a gait abnormality that is not related to a joint disorder that has not been surgically repaired, previously we had one code, abnormality of gait, which was 781.2. We now have multiple codes, including ataxic gait, paralytic gait, unsteadiness on feet, other abnormalities of gait and mobility, or unspecified abnormalities of gait and mobility. This is one code we would not want to see used in home health. If we have physical therapy going out, they should have the specific gait deviations documented in their evaluation. There should be no reason to use unspecified abnormalities of gait and mobility, as your therapist should be providing you with that specific information that you need. Now again, you must identify the condition. Is it difficulty in walking? Is it due to a joint disorder? If it's not due to a joint disorder that has not been surgically repaired, is it the gait abnormality? As we said, is it ataxic gait, paralytic gait, unsteadiness on feet, other abnormalities of gait, and unspecified abnormalities of gait? For localized swellings, masses, and lumps, codes for localized swelling, masses, or lumps are assigned when the documentation does not support a more specific diagnosis. In ICD-10, intra-abdominal and pelvic swelling, mass, or lump is specific to the intra-abdominal and pelvic regions only and would not be reported for a superficial swelling, mass, or lump localized to the skin and subcutaneous tissue of the abdomen unless otherwise indicated in the alphabetic index. There is a specific category for reporting localized swelling, masses, and lumps of the skin and subcutaneous tissue, and codes are specific to this site. Careful review of documentation is needed to ensure that the most appropriate code is assigned. When we look at masses, when we look at ICD-9 versus ICD-10 terminology, previously we had one code in ICD-9, localized superficial swelling, mass, or lump. We now have more specificity. Is it of the head, neck, trunk? Is it of the right or left upper limb? There is, as you see, a code available for unspecified upper limb, but we would never use this in home health as obviously we would have the specificity as to the laterality. As stated on the previous slide, you must now identify the site where the swelling, mass, or lump is located. For edema, edema is, as you know, an excessive accumulation of fluid in the cells or the intercellular tissue. The accumulation of fluid may be due to a number of causes, but it is also a significant symptom, and when documented as such by the physician, it may be reported as an additional diagnosis. Previously in ICD-9, we had one code for edema. It was 782.3. Now in ICD-10, we have three choices. We have a localized edema, generalized edema, or unspecified edema. As with all other unspecified codes, we would not want to use this code as we have the more specific information. As stated on the previous slide, we must now identify the extent of the edema. Now let's get to Chapter 19, Injury, Poisonings, and External Causes. Specific documentation requirements for Chapter 19. We will focus on some of the more frequently reported injury, poisoning, and external causes in home care that have different documentation requirements in ICD-10, including fractures, open wounds, burns, and poisonings. For traumatic fractures, the main guidelines for coding fractures are: if a fracture is not indicated as open or closed, it is coded as closed. If a fracture is not indicated as displaced or non-displaced, it is coded as displaced. And when there are multiple fractures, a separate code is required for each, and the provider should be asked to list fracture diagnoses in order of severity. Initial versus subsequent encounter for fractures are assigned seventh character extensions. The main guidelines for coding fractures are if there are any complications of surgical treatment or fracture repairs during the healing or recovery phase, it should be coded with the appropriate complication code. Delayed healing, non-union, and malunion are reported with the appropriate 7th character extensions for subsequent care. You would not use a traumatic fracture code for a patient with known osteoporosis who suffers a fracture, even when the fracture occurs after a minor fall or trauma, if that fall or trauma would not normally break a normal healthy bone. However, it must be the physician who makes this determination, not you as the clinician. For fracture of the neck of femur, in ICD-10, fracture of femur contains 6 subcategories. Fractures in most of these subcategories are further subclassified with additional information related to fracture site and/or fracture configuration and type, such as transverse, oblique, or comminuted. When we compare ICD-9 versus ICD-10 terminology, in ICD-9 we had 2 codes, either closed or open fracture of the neck of femur at the base of the neck. When you look to the right, you can see how many choices we now have available for that same fracture in ICD-10. Again, with any other type of code, although we do have codes for unspecified, we would never use these codes in home health as we have the more specific information, and if we don't, we are required to obtain it. Again, when we're coding for fracture of the neck of femur, we must identify the site of the femoral fracture. Is it of the neck? And if so, is it the base of the neck, the epiphysis? Is it intracapsular, mid-cervical, of other specified site, or unspecified part of the neck? Is it of the head? Is it articular? Is it of the other specified site, or is it an unspecified part of the head? Is it pertrochanteric? And if so, is it apophyseal? Is it of the greater trochanter? Is it intertrochanter, lesser trochanter, or an unspecified trochanteric site? And is it subtrochanteric? We must identify the fracture status. As we said before, is it displaced or non-displaced? We must identify the laterality. Is it right or left? We would never use the unspecified code. And we must identify the fracture. Is it closed, or if it's open? Is it Castillo classification type 1 or 2, type 3A, 3B, or 3C, or is it an open fracture and we have no more specific information, in which case open NOS would be used. We must identify the initial episode of care. Is it initial? Is it subsequent with delayed healing, malunion, non-union, routine healing, or is it sequela? For home health, obviously, we would always be the subsequent or sequela for the episode of care. We would not be the initial point of contact for a patient with a fracture. Now, when coding open wound of the extremities, in ICD-10, codes for open wounds of the extremities are found in 6 categories. Codes for open wounds are specific as to the site and type of injury. Additional codes are required to report any associated injuries such as laceration of nerves, major blood vessels, muscles, or tendons. An additional code would also be required to report any wound infection. When we compare ICD-9 versus ICD-10 terminology, we see in ICD-9 if we had a patient who had an open wound with tendon involvement of the forearm, we had 1 code. As you can see in ICD-10, we must now state whether it's an unspecified type of open wound, which really is not acceptable in home health. We really would need to query the physician as to the etiology of that wound. Is it a laceration, a puncture wound, or an open bite? And if so, is it of the right or the left? If it's an open bite, is there injury to the flexor or extensor muscle, fascia, tendon, or type of injury to the forearm? And is it an unspecified type of internal injury? Is it a strain or is it a laceration? We must identify the site of open wounds. The upper limb, obviously, is anything from the shoulder down to the finger, and lower limb is from the hip down to the toe. We must identify the type of open wound. As we stated before, is it a bite, not described as superficial? Is it a puncture wound, with or without foreign body? Is it a laceration, with or without foreign body? Or is it an unspecified open wound? This is a code we would only use if you as the clinician absolutely could not get further information from the physician, and this would have to be a very unusual circumstance for that to happen. And again, we must identify laterality. Is it right or left? Although unspecified codes are available, we would not use these ever in home health. We're going to identify the episode of care. Is it the initial encounter, the subsequent encounter, or the sequela? We're going to identify any associated wound infection, and we would use an additional code for any associated injuries to nerves, major blood vessels, muscles, or tendons. Now we move on to burns. In ICD-10, burns are now classified first as chemical or thermal burns, and then by the depth and the extent. Chemical burns are now classified as corrosions, and thermal burns are continuing to be classified as burns. A toxic effect code provides more information on the type of the agent that caused the corrosion or burn and on the intent. Was it accidental, intentional? Was it due to self-harm, assault, or were the circumstances undetermined? When we look at terminology between ICD-9 and ICD-10 for burns, in ICD-9, if we had a patient who had a second-degree burn of the lower leg, we had this code. If we now had ICD-10, as you can see, we would need to know whether it was the right or the left lower leg. Again, as with any other diagnosis, there is an unspecified code available, but we would not use that for a burn in home health. When identifying burns, again, as I stated, we must identify the type of burn. Is it a corrosion, which includes burns due to acids, alkalies, caustics, or chemicals? Or is it a thermal burn, except for sunburns, which include burns due to electricity, flame, heat due to gas, liquid, or an object, radiation, or steam? We must identify the site. Is it external? Is it of the eye and adnexa only? Or is it internal? And again, we must identify laterality. Is it on the right or left? And identify the depth. Is it a first, second, or third degree burn? Again, we would not use unspecified codes for this. As with ICD-9, we must continue to identify the extent of the total body surface area affected by the burn, anywhere from less than 10% to more than 90%, and this information would have to come specifically from the physician. We must identify the agent and intent, and whether it was accidental, unintentional, whether there was intentional self-harm, assault, or whether circumstances were undetermined. For poisonings, in ICD-10-CM, there are 4 general classifications of drug toxicity. An adverse effect is defined as a toxic reaction to a drug that was correctly prescribed and properly administered. Poisoning is defined as a toxic reaction to the wrong prescription or the wrong dose of a drug, or to a correctly prescribed drug taken in combination with a non-prescribed drug or alcohol. A toxic effect is a poisoning from a substance that is non-medicinal in nature, such as alcohol poisoning, lead poisoning, or poisoning from heavy metals. New to ICD-10-CM, underdosing refers to taking less of a medication than was prescribed by the provider or less than the amount recommended by the manufacturer. Underdosing is never a principal or first listed diagnosis. When we compare poisoning ICD-9 for ICD-10 for underdosing, as you see in ICD-9 there was no diagnosis code available as there is now in ICD-10. For poisonings, we must identify the drug and external cause, which is a single combined code, and use an additional code to specify the drug reaction. Is it an adverse effect? Is the right prescription of the right dose properly administered? We would code first the specific adverse effect. Or is it a poisoning? Is it the wrong drug, the wrong dose, the wrong route of administration, or the wrong combination of drugs or alcohol? We would identify the external cause. Was it accidental, intentional, or were the circumstances undetermined? And we would code first the specific toxic reaction due to the poisoning. Additionally, we would identify the drug and external cause as a single combined code and add the additional code to specify the reaction. We would identify whether it was accidental, intentional, or undetermined, and we would code the specific toxic effect additionally. For underdosing, which is taking less than prescribed or less than recommended, we would code first the specific medical condition resulting from the underdosing. Now for our chapter summary. For Chapter 18, the most important changes to symptoms, signs, and ill-defined condition chapter include assignment of a sign or symptom code with a definitive diagnosis code is dependent upon whether the symptom is routinely associated with a definitive diagnosis or disease process. Codes for signs and symptoms related to walking and gait describe conditions more specifically as ataxic, paralytic, or unsteadiness on the feet. And a code for localized swelling, mass, or lump are assigned when the documentation does not support a more specific diagnosis. We must identify the extent of edema as localized, generalized, or unspecified. For Chapter 19, the most important changes to the injury, poisoning, and external causes chapter include when there are multiple fractures, a separate code is required for each, and the provider would be asked to list fracture diagnoses in order of severity. The initial versus subsequent encounter for fractures are assigned seventh character extensions. Codes for open wounds are specific as to site and type of injury, with additional codes that are now required to report associated injuries such as laceration of nerves, major blood vessels, muscles, or tendons, and an additional code is also required to report any wound infection. Burns are classified first as either chemical or thermal, and then by depth and extent. And new to ICD-10, underdosing refers to taking less of a medication than was prescribed by the provider or less than the amount recommended by the manufacturer. Underdosing is never a principal or first listed diagnosis. Our references for today's presentation are the ICD-10 CM Complete Official Draft Code Set from Optum 2014, the ICD-10 CM Clinical Documentation Improvement Desk Reference from Optum 2015, and the Home Health ICD-10 CM Documentation Trainer from Decision Health 2015.